Good afternoon, everyone, and welcome back. If we can make a start, please. Thank you so much. I feel rather perversely I'm stopping conversation just so I can start it again now in the question and answer session. Thank you for navigating your way back through the maze. I've had lots of conversations with people who've been counting their steps, and they're saying the bright side about the location of things is that their step count is looking really good for the day. So welcome back all. I hope the breakout sessions gave you a chance to share experiences, get that sense of different perspectives in the room. And again, that's very much what we want to carry on with now. So you've heard from 3 out of our 5 panel members already, so I don't need to reintroduce them. But let me introduce some new faces to you. So we've been joined by Amanda Campbell, PHSO's Chief Executive. So welcome, Amanda. And we've been joined by Bernard Jenkin MP. Welcome, Bernard. Now, Bernard is the Chair of the Public Administration and Constitutional Affairs Committee, sometimes referred to as PACAC. And it's a really interesting role, actually, that Bernard carries out in terms of PHSO, because PACAC has a really key responsibility in terms of holding PHSO to account. And you heard Rob earlier refer to the annual scrutiny session, which is coming up in December. But it's a dual role, because actually PACAC has a key role in terms of using PHSO insight to then hold public service to account. And that might be something we want to explore during the course of the session. We're very grateful that Bernard's been able to join us. I know you are very much in listening and reflecting mode, Bernard, and making the most of this opportunity. But I'm sure if people have questions that feel particularly pertinent and relevant to you, you're happy for them to come to you accordingly. So we appreciate that. So that's our panel. We started this morning, I keep saying this morning that it was afternoon, it was 12 o'clock. We started the meeting, with some general kind of housekeeping. So let me do some Q&A housekeeping for you now. So firstly, to all of you, I know we kind of had a few things running over in terms of time-wise, but I'm still going to make sure we have just under an hour for Q&A, because this is a really important part of any open meeting. So we will make sure that you have time to raise your points. I said that at the beginning, and we will absolutely do that. So please, again, bear with me and be patient, and I will get to you. But with time in mind, you know that we've got to finish on time. You've got trains to get, caring responsibilities, people to go on to see. So we're going to have to make sure that we do that, and we will. We have a range of people in the room. That's been the key theme, hasn't it, of the day. We've got complainants, we've got complaint handlers, we've got people with that regulatory background, but we've also got health and non-health colleagues in the room. And my challenge, and I need your help with this in this session, is to make sure I try and do justice to the diversity of people, all of whom will have points to raise. So please help me do that. And with that in mind, please introduce yourself so we know your backgrounds and kind of why you're here today. So that's to all of you. To the panel now, I've got some ground rules for you as well. So a simple one, please answer the question. If I feel clarity is needed, I will come back to you. And I am no David Dimbleby. I'm not going to, David Dimbleby's job is safe, but my job today is to make sure that these people get as much as possible from the open meeting. So I'll be doing that. I recognise some questions might be difficult to answer, some might be uncomfortable, some might be very much a work in progress, but we go back to the founding principles of today: openness, honesty and transparency. And actually, Rob and Amanda, I know you know that in terms of arranging today, but Scott, Bill and Bernard, those principles are as important for you as well. And I'm very aware some of the questions might feel quite focused on PHSO, and I want to make sure that they're answered. But again, to Scott, Bill and Bernard, let's bring you in around those broader points, because it's important we kind of lift ourselves up a little bit too. Final warning is to avoid jargon. I don't want to hear about ALRs, ADRs, HSIVs. I just don't want to hear about them. Is that fair? Possibly, because I may not know what they mean, but I will do most of them. Right, that's the kind of rules. And I kind of gave Bernard a heads up before. We do need to kind of make sure I finish this session kind of by sort of 1:45. And I'm going to come back to Bernard sort of just so we can make the most of some final reflections. So you kind of had your warning about that, as it were. Right, let us make a start all. You may remember when you first sort of submitted your response to wanting to come to today, some of you actually submitted some questions that you were keen were put to the panel. So I'm just going to put some of those just to get us started, in a way just to give the panel a chance to warm up, and then we'll open everything up. So with that in mind, can I just check, is Gaynor Goodwin here? Gaynor, welcome. So Gaynor, I don't know, I've got your question. Have you got it too?
Just in case.
Brilliant. Why don't you read that out for us?
Okay.
And as I say, if you can remind, I know who you are, but others won't.
Yeah, okay. So my name's Gaynor Goodwin. I'm a Quality Governance Manager for a clinical commissioning group. So we're a commissioner of healthcare services. My question is, as a clinical commissioning group, I think we're well placed to handle complaints that span more than one commissioned service and offer a joined-up response to complainants. My question is, what does the Ombudsman, does the Ombudsman agree with this approach, and how would you support us to operate in this way?
Yeah. So actually, I'm going to start with Amanda with regard to that one. So Amanda.
Okay, so I guess the starting point is that people that make complaints have the choice of where they want to make the complaint and whether they want to make it to the provider or the commissioner of the service. So we have to respect that and allow people to make the complaints in the place that they feel most comfortable in making them. But I absolutely agree with you that one of the big challenges of today's healthcare system is the fact that often complaints span a number of different providers, and therefore the commissioner and the clinical commissioning group often has a really important role to play in making sure that there is a join-up across that system and a coordination and cohesion of the investigation of complaint handling. So we would of course encourage the CCG to become involved and to step forward and to offer that coordination and coherence when it is a complaint that stretches across different commission services within their area.
Yeah, we had a breakout session, didn't we, that I imagine kind of explored this. Scott, can I just come to you there? I mean, I know yours will be a slightly different perspective, but for those of you who've listened to Scott on Radio Ombudsman broadcast that Rob referred to, you talk quite a lot about the challenge as a service user of that lack of integration, and we often hear about kind of silos, don't we, in terms of working across both health and social care. So that kind of, how that then translates into the challenge around complaint handling.
Well, I think the silos were one of the huge problems that we encountered, and I think the CCGs are perfectly placed to support the local NHS and NHS users. I actually think it's an obligation that you should be delivering upon, and you should be supported in whatever ways you need to do that, because some of the organisations that you're responsible for can't have the capacity to do that. You have a pivotal role to play, and it was a failure in that area that contributed to things going on for us.
Do you want to come back on any of what you've heard, Gaynor?
Just to say, thank you. I mean, I think that's really positive, and I'm aware that not all CCGs take the same approach, which is, I think, why I raised it, to kind of gain a bit of support for that approach. So thank you for that.
Yeah, lovely. Thank you. I want to move to a question from Anne Allen. Is Anne here? Anne, again, I've got your question. This is the classic moment. Can you remember your question?
Thanks. Hello, my name's Anne Allen, and I forwarded my complaint, well, the response to my complaint from the trusts to the Ombudsman. And my question is, does the PHSO send all reports of reviews to the CQC?
Yeah. I'm going to start with Rob for this one. Rob, you often refer to the difference between moral suasion and regulatory sanction, which we don't have as an ombudsman, because I think there's the broader issue there of the relationship between PHSO and maybe regulators more generally. But Rob, can you start us off?
Yeah, thank you for that question. The answer is no, we don't. The question that comes after that is, should we? The test is, by doing it, can we help other regulators to be more attuned to what's actually going on for individuals? And we've heard from CQC that they would like more of it. And there is a danger that the first line bodies in jurisdiction don't undertake their responsibilities to report it back. So it's something we need to look at very carefully. In the context of joining up the regulatory bodies, we're not a regulator, we're part of the regulatory framework. It's a sensible thing to think very carefully about.
Yeah, thank you. Bernard, is there anything you want to come in there? I mean, we talked about PACAC's important role in terms of holding public services to account. Any kind of thoughts on that distinction between ombudsman and regulator.
Perhaps it's just worth understanding the history, which is that the Public Administration Committee originally came into existence when the Ombudsman was set up to be the watchdog of the Ombudsman, and also to receive the reports that the Ombudsman lays before Parliament. That's why it's the Parliamentary and Health Service Ombudsman, because it's independent of government. It's actually funded directly by Parliament, not by the government, and it's answerable to Parliament, and it's why the Ombudsman is actually appointed actually on a recommendation from the Prime Minister, but by the Queen. It's a very, very important post. And the Ombudsman, the legislation says the Ombudsman is an officer of the House of Commons, or has to be treated as an officer of the House of Commons. And so we receive the reports that the Ombudsman lays before Parliament. Now, not every complaint results in a report to Parliament, but if there's a particularly important topic that the Ombudsman thinks should be drawn to Parliament's attention, we receive the report. Then, this didn't used to happen, but this is what we now do. We will study that report. We will offer that report. If it's a health report, we'll offer it to the Health Committee and see if they want to take evidence on that. If they don't, then we will consider taking evidence, and then we will take evidence from the bodies that have been criticised in the report, that have failed, and to ask what they're going to do to make sure that the same thing doesn't happen again. This didn't used to happen, and it happens now. So taking an example on midwifery regulation, I mean, we came back a number of times on infant deaths, and we kept on harrying the government until finally, April this year, the regulation of midwives was changed from the very old-fashioned system invented at the beginning of the last century, was changed, and we have proper independent regulation of midwifery. We also use the experience we have gained from looking at these reports, particularly about the health service, and I'm going to mention it. HSIB, which is the healthcare, the health service safety investigation branch of the Department of Health. It's a new body that the Department of Health has set up, which is independent of the government and investigates clinical incidents in the NHS. And you might have read just this week, the Secretary of State has given it some extra money so it can lead on all these infant mortality deaths. I mean, this is a very, very big change that has come about through the Ombudsman giving Parliament his reports. So, you know, looking back to that earlier slide from Bill about, you know, it's got to make a difference. These complaints that have gone through the Ombudsman, however tortuous and ghastly it was, I mean, Sam Morrish's case, for example, in the end it's resulted in change. We did a whole thing on sepsis, and we absolutely lambasted the, what is it called, NICE, the National Institute for Clinical Excellence, and asked them why they were taking years and years and years to come up with procedures for dealing with sepsis. And you know, it was a typical example of where a bureaucracy was just taking very, very long time to do the perfect thing instead of just getting on and getting something out there to deal with the crisis in sepsis. Sometimes, you know, it feels like us we're pushing water up a hill, but that's what we do.
That's what we do now. I think that's very helpful. Bill, did you want to come in there at all in terms of picking up on that learning point?
I think that it's fair to say that we, in the health service, we have struggled with things that cross different organisations and things where a system response is required. And I think any help that we can get, whether it's from involving CCGs or whether it's from involving CQC, to address these issues where there are clear systems learning points, but everybody looks over their shoulders at the next organisation along the line and says it was them, not us, is absolutely helpful, is needed.
Yeah, lovely. Thank you very much for that. I've got some more pre-submitted questions. We may come back to them during the course of the afternoon, but I do want to start kind of opening it out now. So can I kind of have a show of hands and get a sense of who would like to make a point? And then I could kind of work out whether I need to do some clustering. So can we have Lynn? Can you, we kind of have to sort of shuffle the microphone over a little bit. Can we go to Della, please? Okay. Thank you.
Hello, my name is Della Reynolds. I'm the coordinator for PHSO The Facts, and my question's really aimed at Dr. Kirkup. In a recent article in Health Service Journal concerning your investigation for Mr. and Mrs. Dixon, you said, "It is clear that they have had significant concerns, and those concerns haven't been addressed for more than 15 years. That is going to take an awful toll on anybody." You went on to say, "It is clear this isn't an isolated example. It is bad enough that there is one case, but it's clear there are others too. It causes untold harm to people when we fail to get this right, and the longer it goes on, the worse it gets for them." So what advice would you give to members of PHSO The Facts who have submitted historic cases of injustice to Mr. Behrens to be told that our only option is to go for judicial review, which is no longer an option in any event?
I stand by the comments that I made in the Health Service Journal. I think that when we fail to get things right, it does cause untold misery. We should have a mechanism for looking at these. The fact is that we don't. I'm not convinced that PHSO is the right mechanism for looking at historic cases. When I was a member of the advisory group that was advising on setting up the Health Services Investigation Branch, we did say that we didn't think that HSIB, sorry for the jargon, was the right body either, because it could easily get submerged by historic cases, and that there was a gap there which needed to be filled. That ball is with the Department of Health, I think, at the moment as to how it might best be filled. I know that people have been talking about it. I have yet to see any concrete product of those discussions.
They're not all health cases, actually, that go to Ombudsman. There's Parliamentary as well. Okay. And the group is growing bigger every year. So we just want some resolution, please. Thank you.
Okay, thank you for that, Della. Rob, did you want to come in there, or shall we? I know you're keen to speak. So shall we maybe have another question and then maybe come back to Rob?
Well, I'm going to ditch my question just to remind Mr. Jenkins that his committee a couple of years ago in report did make a strong recommendation based on the expert advisory group's statement that there should be a Hillsborough style or Savile style, or we could now say Grenfell style, or contaminated blood products, anything, to look into these kind of historic cases of failure and of death, and also the whistleblower cases. And we have heard nothing more about that since.
Well, I dare say it's a recommendation to which we will return, but I don't want to get anybody's expectations up. The committee I chair would be completely ill-equipped to conduct that kind of inquiry itself. It would have to be done in a different forum.
Okay. So if I could just ask my question, I'll be very quick. Okay.
Do you want to explain
my name's David Drew, sorry. I'm a retired or sacked paediatrician, sacked for gross misconduct and insubordination, so you may not want to take any further notice of what I say. But the one thing that strikes me is Scott's given eloquent testimony to the failures in the NHS complaint system. Bill Kirkup has talked about it at a wider public body level, and Rob Behrens in HSJ and the Times has said that, I don't know whether he used the words not fit for purpose for the NHS complaint system, but certainly there are major problems with it. Given that, how come it must be that many people who experience failures in the NHS don't bother to complain, or if they get turned back at the trust, they don't go to the PHSO. So the complaints that you receive are just a small part of it. Given that, why do you think it is that such a small, it's such a bad complaint system, and it is, we've all experienced it. Why is it that the assessments result in so few, such a small percentage of the complaints being investigated in the first case, and when they're investigated, only a relatively small number get a satisfactory response, and hence the need for a meeting like today?
Okay, thank you for that. Let's go to, I think, Rob and then Amanda for that. So we've got sort of the point about kind of the sort of flow through in terms of kind of what's coming into the system, maybe picking up on what certainly other sectors refer to as silent sufferers, so people who never even make it into the top of the complaint system. So Amanda, that might be one for you. Before we come to you for that, Rob, this kind of issue that Della had raised and reflecting on what Bernard has said as well.
I've had exchanges about this. I think there's a difference between the argument for historic review, which is a strong one, and whether or not that should be undertaken by PHSO. And my considered view is that PHSO is not the vehicle for it, though I'm prepared to listen to and argue the case for it being done. So that's the first thing. As far as Dr. Drew is concerned, I read what he says with great interest. He has a major contribution to make to these debates, and he should be taken very seriously. I have never said, and I'm not saying you did say this, but I have never said that PHSO is not fit for purpose.
It was the NHS complaint system that I said.
I'm confining myself to PHSO at this moment. It has been suboptimal in some respects, and it needs investment and change in order to make it even more professional than it is. And I think to deny that is really to live in cloud cuckoo land. So I think that's my position as far as that's concerned. But you raise a very interesting point, which is not just about PHSO, it's about all ombudsmen. And that is it significant, the percentage of cases that are found justified and partly justified? Given that the Complaints Commissioner at the Bar found 10% of cases justified, the OIA, the Higher Education Ombudsman, finds 25% cases justified, and PHSO finds around 35% of what it investigates justified. There is an issue there of to what extent should there be an optimal number, which I think would be difficult to try and target. But for Ombudsman research, and you've got Dr. Richard Kirkham behind you, who's a leading expert on this from Sheffield University, it is true that satisfaction with Ombudsman services depends largely on the outcome of the complaint. So if you have a justified or partly justified complaint, you're more likely to find the service satisfactory than if you don't. So we have to factor that into any feedback that we're getting, and Amanda can talk about that, to make sure that we're not dependent on the outcome of the case to test the reasonableness of what we've done.
Amanda.
Okay, well, I'll maybe finish that point first. I think one of the important changes that we've made in PHSO over the last 18 months is the introduction of the Service Charter. And that is a very public statement from us about how we're doing. And what we do every quarter is an independent company, independent of PHSO, telephones around 600 complainants who have experienced our service and are at different stages in our service. So ones that are at the sort of intake stage, those at assessment, those in the process of an investigation, and those whose investigation has been complete. And they're asked a series of questions about how well we have done. Then we gather all of that information together and we publish it on our website so that we can be challenged and held to account for the service that we deliver. And what we do is look at that information and say, where are we getting it wrong, and where could we be better? And are there certain parts of our process where actually the service is very different for complainants, and therefore can we focus our attention on those areas so that we can try to understand more about why the experience is how it is at that part of the process. So this is very early stages for us. We have three quarters worth of data now on our website for everybody to see. But we are quite unusual as a public service in doing that and allowing ourselves to be held to account for it. And we are very keen to speak to people about their experience of our service, and this is an example of it, so that we can get under why it feels different in different places. And if, as Rob said, it's about the decision, or it's about how we communicate the decision, how we explain it, how we listen. I was listening at the back of the session with complainants just now, and what is very clear is that there have been a lot of occasions where we just haven't got that right, and we just haven't listened well enough, and we need to get much better at that. But then coming on to the sort of broader question about complaint handling across the system, what I would say is for our own service, but also for the wider complaint service, there is a real variation. And so there are a number of examples from within my own organisation of absolute excellence in terms of dealing with complainants. And I see the same in parts of the health system of real excellence of getting it right. So we should recognise that and say that. But it's not consistent, and that's true across the whole of the healthcare system in terms of the approach to complaint handling. And I think there is much, much more that we can do collectively to improve that. And we've talked a bit in our consultation document about how we want to do that, how we want to do more to improve the overall quality of complaint handling in the complaint system. So you'll hear more about that, and if you have ideas about that, then we'd be delighted to hear those.
Can I maybe bring in, is John Dale here? John, thank you. I know you had an interesting question that kind of picks up on, again, what PHSO's role, responsibility should be with regard to first-tier complaints handling. Do you want to raise that now?
Yes, certainly. It's something that was, I think, embraced across certainly the complaint handlers group. When you visited, this is for Rob, when you visited our conference in Liverpool a couple of weeks ago, you spoke about the PHSO providing courses for investigators from NHS organisations. I assume that would be from all organisations, actually. I have not seen this, though, in the forward view that you give in your draft strategy. Wondering whether or not you'd comment on that.
Yeah, thank you. I came to Liverpool and Lime Street station was closed, so I went to some other station and I couldn't find my way around, and I was looking at a map and two guys came up to me, one on either side, and I thought, this is the moment when I'm going to be beaten up. And they said, we're doctors, can we help you? And so I said, well, I've come for a conference. So they said, well, what do you do? And I thought I'd better not tell them what I do. But look, this is absolutely fundamental to the role of a classic ombudsman, that there must be some support to the bodies in jurisdiction to help them resolve complaints more effectively, so that people don't have to go through the trauma, as Scott and Bill described, of going through the whole system. So we want to reduce the number of people who come to us by helping you and bodies like you to do it better. And we recognise that there is a job to be done. But the truth is we've just taken a massive 25% hit in our spending. And we're not easily going to take on new roles in a situation where we've had to lose 80 valuable members of staff, experienced complaint handlers. That is serious for us. So my commitment is absolute, and it is in the plan. Perhaps it needs to be set out more clearly. It will be in the final plan. We will give support, but we can't do it on our own, and we can't always do it physically. We might have to do it remotely, but there are good examples of how to do it, and we'll follow that. So you have absolute assurance that there will be support.
Yeah, I'm hoping that you won't do it on your own, in fact. I'm actually hoping you'll do it with a university and get a proper degree course for investigators and complaint managers, where it gives them some gravitas with their directors, that what they say goes.
Yeah. Just with that point in mind, accreditation, that makes me think of Amanda.
Let me say a little bit about that, because it is something that I feel really strongly about. And coming into this role a little while ago, it was something that I sort of set out very early on that I wanted to do, not only across the wider system, but also for our own staff within PHSO, I think it's really important that there is a recognised professional standard that we work to, that we set that out and we make sure that at PHSO we're at the forefront of that, and that everybody can have confidence in the level of training and discipline that our team goes through, and that once we have moved towards that recognised accreditation, that we can then look at how we can spread that more widely across the system. We're not the only ones looking at that, really encouragingly there are other parts of the health system. HSIB, as Bernard described, is looking at the issue of professionalisation of investigation, and I know the CQC are doing the same in relation to their own roles. So we're talking to all of those about how we can do that in the best way, how we can use professional expertise to do that, but generally how we can raise the standard of investigation across the system.
Okay, I saw Bill wants to come in there.
Just a brief addendum to that, if I can. I think there's another side to that coin, and it's about raising the status of complaints handlers in their own organisations, because at the moment they're not high status and they don't get the support that they need and the backing that they need to do an effective job. I don't think that's a role for PHSO to take on, not least because a lot of the time we're criticising complaints handling in organisations, it wouldn't fit very comfortably. But I'm sure that somebody needs to do that.
Sorry, can I just chip in?
Please do, Bernard, yes.
Scott, sorry. Every NHS trust should have a senior executive on the board who is visibly responsible for complaints handling. A senior non-executive director should also be overseeing complaints handling, and every trust board should regularly review a selection of complaints so that they're in touch with what's going on, and the same with CCGs. And in our report, we envisage that HSIB will eventually, the Health Service Safety Investigation Branch, will eventually be setting up a college or an academy for complaint handlers. That there has to be a proper curriculum, there has to be a proper profession, and these people should exist throughout the health service. The health service record on handling of complaints is lamentable, and there are very, very few points of light in the system where complaints are handled properly.
Okay, I want to hear from Scott, and then I know there's somebody who's been waiting patiently to ask a question. I will be coming to you, Scott.
I was just picking up on what John, Della and David have said, really, and that is, in a way, about complaints and historic cases. Complaints handling can be viewed as a barometer, if you want to, for our cultural values. And the truth is that it all boils down to leadership. If the complaints themselves are not valued, if they're not prioritised, you know all you need to know about the culture. It comes down to leadership, and it's summed up by the people who are trying to do their best, but they feel unsupported, unvalued, they're under-resourced in terms of training as well as money. And if you then come back to historic cases, it's a test of our collective emotional intelligence and our psychological literacy. If you want insight, if you want understanding, if you want learning, and if ultimately you want improvement, you cannot afford to ignore that well of hurt that's out there. You've got to do something about it. I also actually don't think it should be the PHSO. I don't think they're able to do it. It should come down to government, the Department of Health, and I'm obviously focused on health, but other departments need something similar. You can't just leave us.
Yeah.
Okay.
Too much is lost.
I see Bernard making a note there. There's just gentlemen here, so then if you could pass, and then we'll come to you at the back as well.
Oh, right.
Thank you.
Hello. It's Dan Maloney and my wife representing our daughter mental health case. But first, that's last subject. It's the best thing I've heard here today. And Bernard indicating that it's going to be independent of PHSO seems absolutely right. And it is obviously not just for the PHSO investigators, but for the trust investigators. That really is the thing for the future. I'm really happy with that. My question is about investigations in the PHSO for mental health cases, specifically specialist mental health cases, such as acquired brain injury, that sort of thing you get in a car accident, and possibly learning difficulties. Question, particularly for Rob, Mr. Behrens, why does the Ombudsman still use general practice psychiatrists as advisors in specialist mental health cases? That's the first question. That creates, and I ask whether you understand it or not, certainly our experience is, that creates within the Ombudsman Service a discrimination against mental health patients compared with physical health cases. The example I've given is, would a knee surgeon be accepted as an advisor for a heart surgeon ombudsman complaint? And the answer is obviously no. So why a specialist acquired brain injury condition, which very limited people understand, Maudsley Hospital being the thing that most trusts send their patients to. So do you accept that represents, to some degree, a discrimination against mental health patients when they hit your system?
Okay. Should we put that
well,
to
that's
Rob?
two. There's four bits.
Oh, you didn't say that at the beginning.
The Ombudsman does not support the House of Lords recommendations and report on the Mental Capacity Act 2005. They did that in 2014. Specifically, they've said it's not relevant. It's not relevant to individual complaints. Yeah. That cannot be so when the complaint contains several issues where the Mental Capacity Act of 2005 has not been applied, but it's in its place the old-fashioned clinical decision. The psychiatrist says, I think this doesn't have to have much of a reason why, and does that, those comments appear in reports from trusts within a mental capacity investigation.
Okay.
So
and is that your final point, Mr. Maloney? Because I want to get these two
almost
people so they can answer. Let's do quickly your final
I have
point.
written to Mr. Behrens on it,
yes.
and I'm awaiting a response from him.
So your final point is a chaser. Okay. All right. Rob, shall we start with you there? So there might be a broader issue there as well to start with around the role of clinical advisors within the Ombudsman scheme. Bill, I'm guessing you will have views on this, so I will come to you.
Sure. Thank you for that considered question. I want to answer it generally, first of all. The point about clinical advice means that PHSO is different from a lot of other ombudsman services who do not have power in law to look at professional or clinical decisions. So most ombudsmen do not have that responsibility, and that gives a huge responsibility on PHSO to make sure it has access to appropriate clinical advice. Now, in my first period at PHSO, I am hugely impressed with the quality of clinical advice that we have, but I'm not convinced that everyone believes it's as impartial as they think it ought to be. And that's the reason why I've said that we will review clinical advice as part of our new strategic plan. And in doing that, I promise you that we will come to you to take your view on this specific issue.
Me personally?
Yeah, you personally.
And my wife.
And of course your wife. And we will take your view so that rather than just say yes, 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 we'll look at it and we'll come back with a considered response.
Okay. Bill.
Thank you. I think that where the issues in a particular example revolve around technical details of practice, what you say is undeniable. I think I would observe that in a number of cases that I've been involved with, probably the majority, the issues aren't actually deeply technical ones. They're actually pretty fundamental basic stuff about the duties of a doctor or the duties of a nurse. And you don't need a specialist to advise on that. There are actually hazards of having somebody who is too closely involved in a very small specialty. It's sometimes better to have a bit more perspective. But a lot of the time, you know, I don't need an expert to tell me about the duties of a doctor. I've been a doctor since 1974. You can over-specialise on some of these things sometimes. I absolutely welcome what Rob has said about the question of reviewing the way that clinical advice is sought and provided. I think it's right, and I think it will bring benefits.
Yeah. There's somebody at the back who I want to go to, but just before we move on, Mr Maloney also raised the issue of the Mental Capacity Act. And again, I don't know if that's a broader issue that Amanda or Rob might want to pick up on around the vulnerability, I suppose, of people who might use our services.
It was the misuse of the Mental Capacity Act.
Got you.
Okay, and as explained by the House of Lords' wonderful report, House of Parliament, wonderful report in 2014.
Yeah.
It's a wonderful report of how it absolutely destroys the trusts from the point of view that they're not applying.
Okay.
It's 2014 and it came in, it was 2005, it came in 2007. So in 7 years, they are not applying it at all.
This is at the trust. This is at the trust level.
Because
okay.
The psychiatrists want to make their own decisions.
Okay.
They don't want to be told what to do.
Okay. I'm not sure whether can PHSO add anything to that. I don't think necessarily we can, Mr Maloney, but I think you've got people in the room who might want to share their views on that. Gentleman's patiently been waiting at the back there. Thank you.
Hello. Yep. My name's Jason Ginnelly. I'm a complainant about my late father's case that I took to my local trust. I took to the PHSO, and I've even been in touch with Mr Jenkins' committee as well. The question I've got is sort of like in two parts.
Okay. Jason, can I ask you to do me a favour, which is if you can be as quick as you can on those two parts, because I can see it, but thank you. Yeah.
I want to know, where does learning not blaming help grieving families when they can prove and provide criminal, neglectful behaviour has taken place in an NHS hospital and has led to their loved one's death, and we bring the evidence that clinicians have falsified documents, they've told lies, that has then upscaled further up through the trusts in clinical governance, then to boardroom. We've then come to the likes of the PHSO to help us get resolution and accountability. Yeah. It's not worked. Okay. And also then in turn we've gone to the likes of Bernard Jenkins and the committee and also Mr Hunt, etc. Yeah. And this leads on to the second point, that there seems to be the elephant in the room question is that we're not saying, I think it's either 1.3 or 1.6 million people work in the NHS, and we're not saying all those people are criminals. But there are a number of people who work in the NHS who've got God complexes, who look at people, whether it's of their own volition or it's coming from within the trust, and they look at people and they're prematurely ending their lives. They're getting away with doing it, and sadly, MPs are letting it happen and looking the other way. The Ombudsman, etc., are letting it happen and looking the other way. And sadly now, Scott, I'm really feel for you about your son. But I remember, I think it was December 2016 last year, you sat in front of Mr Jenkins' committee and you said there's no corruption in the NHS. I've got a document here. Sorry, I am finishing.
Yeah, okay, thank you.
That has got falsified evidence in it. And you are saying, on behalf of all of us that on the committee or whatever it is you represent, and I've spoke with you at other events before about this kind of stuff, and it's gone in one ear and out the other, the fact that there is criminal behaviour taking place in the NHS, no one wants to deal with it, and while ever it won't get dealt with, the trust levels of us, the public, will never be repaired, because until these people are brought to justice, our loved ones are being disrespected and still keep being disrespected to this day.
Okay. Jason, thank you very much for that. Scott, I will come to you because I can see you kind of want to pick up on that. I'm actually going to go to Bill first, because Bill, there's a really interesting quote I read from you, where you said, because I think this issue of kind of blame and accountability, this balance, and you said individuals must remain accountable for their side of that contract, and if we try to fudge this as entirely a systems failure, we will miss an important point. So can I start with you, then we'll do Scott and Bernard. You might want to come in there.
Thank you. There's a lot of holding me to account for things I've said in the past here, which is great. Thank you. That was about what I call the unspoken contract, where people, by and large, accept that sometimes things go wrong and sometimes mistakes happen. but that the other side of that contract is that they will get openness and honesty and full disclosure and proper learning occurring from it. And I think we have an unhealthy emphasis in a lot of the things. I'm not talking about PHSO here, I'm talking about the NHS generally and a lot of the regulatory machinery around it and the professional regulators. We have a kind of unhealthy focus on pursuing people over whether the mistake they made was sufficiently bad that it was incompetence, and therefore we strike people off and all the rest of it, which I think is largely inappropriate. Not always. Sometimes there are people who are genuinely so unsafe they shouldn't be practicing. But more often than not, that isn't the root problem. The root problem is exactly as you've described, sir. It's the lies and the cover-up and the falsification that happens afterwards. And it seems to me, singularly fail to hold people to account for that. We go after them on the grounds of their competence and whether that's sufficiently bad that they get struck off. Whereas what we should be doing is saying, no, we understand about error, but you have to own up and accept it and be honest about it and learn from it. But once you get into the territory where you're lying and covering up and falsifying, then we will pursue you. Yeah. That's my view. Okay. I was talking to the Nursing and Midwifery Council just 2 days ago on that very issue, and I think they're starting to think in those terms, but it's going to be a slow journey.
Yeah, because the role of regulators is key, isn't it? There, I want to bring Scott in and Bernard in, and then, as I said, if you can help me, because then we're into our last 10 minutes. So, if I want to kind of get a sense of questions, and can I actually say I'm very aware that we focused on health, and I absolutely understand why that is the case. But for colleagues who maybe come from a non-health background, if you feel you haven't had a chance to kind of raise points from your perspective, now is the time. So let's do Scott and then Bernard.
Okay. Firstly, I'm also sorry about what's happened in the case of your father, and never have intended to suggest that criminal activity should not be punished. Every time I speak, I try to make it clear that we should separate learning from blaming, understand that they're different, put different mechanisms in place to deliver both of those things. I don't think you can have one without the other, and neither one is more important than the other. You need both, and they're both vital. And it's not a case of condoning anything that happens if it's owned up to. It's learning from everything, and for that, it needs to be owned up to. It's then singling out the things which were malicious or reckless or negligent or, and I always add, cover-ups. Those things should all be punished and driven out of the system. And then you cleanse it and you build trust, and people like us don't end up misunderstanding what's going on.
Okay, thank you. And Bernard?
Yes, this problem of the blame culture is what leads people to do the wrong thing and not be open and transparent, and probably makes you feel that the evidence has been falsified. When we were looking at clinical incidents in the NHS, and I do urge you, if you haven't read it, just Google PASC, P-A-S-C, clinical incidents, and the report will come up. We looked at how the aviation safety system works, and it's very, very strong on this no blame culture. That doesn't mean that if a pilot does something really bad, he's not going to be prosecuted. He will be, or she will be, but the whole principle is a no blame culture, so that in the cockpit of an aeroplane, if the plane lands badly, the co-pilot might say, I think we ought to report that to the aviation investigation branch because I don't think we did that right. I think we put the passengers at risk. And the other guy will say, okay, that's absolutely fine. There's no blame. Because what they want to find out is why the mistakes were made. And I almost guarantee 95% of mistakes in the NHS are due to understandable human error. And you heard earlier how the clinicians have got this, I mean, we all remember Carry On Nurse and Dr. Robertson Justice. You know, that's the caricature that he was God, everything he said was right, he could never make a mistake. And that is still ingrained into the General Medical Council's disciplinary procedures. Okay. That if you've made a mistake, you get struck off. This is the wrong culture. So what we're about here is a complete change of culture. But let me just reassure Jason, I mean, if there is falsification of evidence in an investigation, that should be reported to the police. But I'm afraid you will find that the police require a very high level of proof that it was deliberately falsified.
Okay. What I want to do is, Jason, I'm so sorry because I know you want to come back in there, but just as I say, it's helping me to kind of keep time. Can I have a show of hands in terms of kind of questions that people want to put? Because we might just need to do a kind of quick fire round, as it were. So I can see gentlemen kind of there and there. So can we get mics to both people who have questions? And can I ask both of you if you can keep your questions as succinct as you possibly can, or your points as succinct as you can? We'd be grateful. So we'll hear from gentlemen at the back and then. Please.
Hello, my name is Will Powell. My little boy died in 1990 of gross medical negligence. The NHS covered up his death. It did go to the police, who initially covered it up because the doctors were retained as police surgeons. I eventually had 35 suggested criminal charges against the doctors. The CPS agreed that there's sufficient evidence to charge, and they didn't charge them because of the passage of time, which was 13 years, caused by the cover-up of the NHS, the Welsh Office, the police and the Crown Prosecution Service. So you're quite wrong there, Mr. Jenkins. The police do not act on medical negligence claims. Okay. And also the Medical Defence Union and the Medical Protection Society, who purport publicly that they advise their members to tell the truth, actually represented the doctors in my son's case to have it thrown out of the court, saying they'd no duty of candor to tell the truth. And I identified through the European Court of Human Rights, the Court of Appeal in this country, the High Court, that these doctors have no legal duty to tell a bereaved parent the truth about the negligent circumstances of the child's death, nor refrain from deliberately falsifying records. Yeah. So it's very difficult to make doctors accountable. Yeah.
Bill, you might want to pick up on duty of candour. I don't know, kind of possibly in response to that. But let's have final question, and then we can do some closing remarks.
Hi there, Andrew Wilkins, Head of Patient Relations at University Hospitals Coventry and Warwickshire, NHS Trust. I was just wondering if the PHSO think there's any room to focus a little bit more than we may do at the moment on best practice, and that links into changing culture. Yeah. And there can be a lot of focus on bad practice, but can we learn more from the excellence that is out there in complaint management? Okay. And then secondly, just quickly, we've talked a lot about raising the standards of complaint handlers, which I think is absolutely crucial and valid. And I get the gist that that's about empowering them to change the culture within organisations. I don't know today how many chief executives are in the room, but is there a need to have the senior management more involved in events like this, given the importance of the conversation happening today?
That's a very good point, Andrew. Let's do so. Bill, I don't know if you want to kind of pick up on anything with regard to Mr. Powell's point. Then let's do Amanda and Rob, and then we need to draw things to a close. So, Bill.
I can only endorse what Will has said, that I have seen a number of times, and I'm really sorry that he's suffered at the hands of this, where organisations don't just get into managing their own reputations, they get into managing each other's reputations. And it's almost as if once you start down a slope of falsifying evidence, nobody feels able to break the cycle. Everybody ends up reinforcing the previous falsification of evidence.
That is why we're coming to you, though, so
yeah.
to interject. Yeah. We need you to break that cycle.
Yeah.
We keep coming to you, and you keep ignoring us and looking the other way. Something eventually has to give.
Okay. We need a mechanism to address those issues.
Yes, I agree.
Should I be denied a conclusion to my complaint that I made 13 days after my son's death, after watching him die needlessly? I made a complaint 13 days later. It's never been concluded because of corruption, and I have nowhere to go. Okay. And it's about time somebody addressed that mechanism. And I was a member of the expert advisory group with HSIB, and it was doing my work there that we had recommendation 13, which is about historic cases. And if anybody says any different, it wouldn't be the truth. Because I fought hard for that recommendation. It has to be applied. Okay. We need a mechanism within the NHS to address historic cases and any NHS cover-ups you have.
Yes,
okay.
I could not agree more.
Thank you very much. You've got a lot of agreement in the room. I say let's have some final comments from Rob and Amanda. Amanda, shall we start with you and then go to Rob?
So coming to your point about best practice, I completely agree. I think there's lots of evidence to say that if you share and focus on repeating the good, that actually things get better much more quickly. And so part of what we want to do in terms of working with complaint handlers across the system is to do exactly that. And to share where people are getting it right and try and help them to replicate that. In terms of the chief executives being in the room, one of the certainly roles that Rob and I play is to go around the country and to talk to chief executives and to chairs of trusts and to really emphasise the importance of the complaint handling teams and the complaint handling process. And we talked earlier about the need for that to be, Bernard mentioned, you know, a core part of the board activity, and certainly it is a very strong message that I give as I go around and talk to senior people at trusts around the country.
Okay, thank you for that. Rob?
Yeah. First of all, Mr. Powell's case is a chastening one which we all need to reflect on. In my view, it emphasises that historic review cannot reside with PHSO. It's wider than that, it's much more serious than that. But we should be commenting on that. That's the first point. The second point is, coming to Mr. McKinley, in order to be professional, complaints handlers have to be sceptical and rigorous in questioning the accounts of bodies in jurisdiction, not just to accept it because they've tabled it. Now, one of the things I learned from the Titcombe case, there was that long ago PHSO and CQC decided not to investigate it because some of the papers had gone missing. And their view at the time was, well, we wouldn't find out the truth because the papers had gone missing. But the real question was, why have the papers gone missing? And subsequently, it's been shown that there was a cover-up. So, you know, I understand the point that you're making. My last point is to Andrew Wilkins about what he says. And can I say two things? One is, when I first came in and went around hospitals, they said, we're fed up with you telling us bad news about the NHS. If you want to be listened to, you've got to give us some good news, and you've got to promote good practice as well as focusing on the poor practice, particularly when you have some poor practice of your own. I think that's absolutely right. We have to find ways of promoting the good practice rather than rubbishing the whole operation. And my last point, the challenge is a great one. When you go out to hospitals, as I'm doing, it's segmented. The more positive news comes from the top of the organisation. So you speak to the board members, the chief executives, and you get a very positive account of how complaints are handled. You go to the clinicians, and it's slightly more sceptical. And then when you meet the complaints handlers, they say, help, we need help and support for all the reasons that Scott has just described. So we cannot afford not to involve the board members and the chief executives. And I think Bernard was just talking about what is required of boards in terms of responsibility. In general, that doesn't happen. That has not been implemented, and it needs to be implemented.
Rob, thank you very much. Bernard, you've heard a huge amount this afternoon, and we've been very grateful that you've been here, but can I give the final point to you? What are you going to take back to the House from this meeting today?
Well, first of all, thank you for inviting me to be here. I wanted to come because I wanted to get the atmosphere and find out whether this meeting was really going to be worthwhile. And I think, I mean, hands up who think it's been worth having this meeting. I mean, I think that's a fantastic response. I mean, and let me just pay a little tribute to Rob here. This has never been done before. This is quite brave. I mean, the culture is, and I get it in my committee too, from my committee staff, oh, you must never meet the individuals. Oh, no, you must never do that. That's a very dangerous thing to do. And the Ombudsman staff and the committee staff get together and they both nod gravely, oh no, we must never meet the individuals. And we actually had a private session a few years ago, and it was an eye-opener. And I mean, the people here are from various parts of the NHS, and thank you for coming, because you're engaging with something that takes up so much time and costs so much money, and where we could do so much better. Every complaint is a gift. every complaint is somebody wanting to give you some information to help you make the health service better. In fact, we do Google again, PASC, more complaints please. We did a whole inquiry into complaints across the whole of government because actually good organisations like complaints. They're a good thing. And I think it's really adverse that CQC marks trusts down for having too many complaints. It's a really, really stupid target there because that means they want to cover up complaints. So thank you for coming along. You've got PHSO professional people here, and it's an incredibly difficult and demanding job being a complaints handler because anybody who's complained will know what a terrible stress you're under if you're complaining about something really serious. And that stress is, they deal with people in stress every day, and the stress goes home with them. They sometimes can't cope with it, frankly. And I know from my own office, because my office get people ringing up, and the committee office. But the third lot, so let's thank them for coming here and being engaged. But thank you for the complainants coming along, because you are the tip of an iceberg. You are a tiny proportion of these thousands of people who are complaining through the Ombudsman every year. Okay. And for you to come along to this meeting is absolutely fantastic, because you're the ones we're learning from, more than anything.
Okay. Thank you very much.
One of the most useful things that I think came out, Robin, we'll hold you to account on this, that remember, by the time you're getting the complaint is about how the complaint's been handled, the Titcombe point you made. It's not about the complaint itself, it's about how it's been handled. How many times MPs have had people in their offices and their surgeries, and they say, I don't really want to complain, I just want to make sure this doesn't happen again. Yeah. And when the door's slammed in your face and you get nowhere, you finish up talking to lawyers and being very hurt and upset and angry and feeling so betrayed. One of the lessons of aviation safety is that the families of the victims are held close to the whole process throughout, and they can be kept informed throughout any investigation about a death or serious injury. Okay. So I think it's been very, very successful. Good. I can see you're looking at me very sternly.
But in a really polite way.
Thank you for inviting me along.
Thank you.
I think we're all learning a very great deal,
Great,
and the work is not finished.
Thank you very much. Can you join me, please, in thanking the panel? To bring things to a close in 8 minutes, I hand the enviable task of summing up what has been a really special meeting to Amanda Campbell, Chief Executive.
Thank you very much, Elizabeth. So my job is to conclude proceedings for today, and what a great afternoon it's been, certainly for me, listening to all of you, both here and in some of the breakout groups, but also listening to some of our fabulous speakers. So obviously we started the day today with Rob talking about his vision for PHSO, talking about how he wants us to act and behave, and about how we're going to focus going forward with our new strategy and what we're going to do. And really importantly, about how we can be demonstrably independent and impartial and be an exemplary public service ombudsman. We then heard a truly inspirational talk from Scott about the tragic avoidable death of his son Sam, but also really importantly the terrible failings that happened in the investigations that followed, and how it was all of his effort that was about trying to just discover how things happened and why they happened, and all of the blockages and terrible things that happened for Scott and his family along the way. And if it wasn't for their own personal determination to have the system learn from those mistakes, we wouldn't have had all of the changes that have been made in relation to sepsis. So thank you very much to Scott, and really important lessons, I think, for us in PHSO when he talked about making trustworthiness our obsession. And I know Rob heard that, but I heard that very strongly too. And then on to Dr. Bill Kirkup, who really reinforced the importance of learning from mistakes from all of those various investigations that he's been involved in. And he once again talked about the importance of trust, both winning trust in the first place, but also keeping that. And we've heard a lot today about trust being a real issue. And he spoke of cognitive dissidence, really interesting, about the whole culture of the NHS and about the sort of blame culture and the fear of blame, and therefore the sort of not wanting to accept that things have gone wrong and sort of distancing yourself from that. And that's to some of the cover-up points I think we've been hearing too. And Bill left us with the really important challenge for us as those investigators in the room about having the courage to investigate thoroughly and properly and really make a difference. We then had the breakout sessions, and I walked around a number of them listening to the conversation, spent a lot of time in the session with complainants. But there were some really key points, I think, that came out of all three of the sessions. So in the session where there were a group of regulators in the room, talked about the need for clearer accountability, about better leadership at a national level to model the behaviours that we expect across the system. But also an interesting idea about having a central hub to signpost people to where to make their complaints and how to do it, because it's a really complex system that doesn't help. And then in the complaint handlers session, there was a lot of conversation about the importance of knowing when to apologise and how to apologise and really meaning it when you did. But also, as we've heard in this conversation now, about the lack of senior buy-in sometimes at trusts and the importance of that. And we have a role as senior leaders in the system to help with that. And then finally, in the complainants session itself, some really powerful interventions about not being believed. And that's something that sort of really hit home with me, about why when you say something has happened, is it less believable than if somebody at a trust or in a government body says that something has happened, and how we reconcile that and how we listen more to you. So back again to trust and what we've got to do better. And the Q&A now, this most recent session, a really great opportunity for us to hear from you personally about the things that are important to you and what we need to do to help and improve. So I have been in PHSO myself just over 12 months now, came in as the Chief Executive this time last year. And I came into an organisation, as many of you have described, as one needing quite significant change. And whilst the organisation had achieved a lot over the preceding few years, and I talked about the service charter earlier and how important things like that are, what was clear to me is that we weren't delivering a consistently high quality service that was meeting the demand that was coming through the door. Now we clearly and do have lots of excellent people working really, really hard to do the best job that they can do. But what I found is that they didn't have the systems and the support to help them do that in a consistent way. And I found, as Rob has described, the need to make a 25% budget reduction. So all of that creating a very challenging situation. So we needed to do a number of things over the last 12 months. One was to reduce the size of our workforce. And the second was to take a really tough decision to actually downsize our London operation and move a lot of our business to Manchester, where we could operate in a much more cost-efficient way and a much more efficient way more generally. But that's meant a really difficult year for our staff. Really unsettling time as people have left PHSO. We've had to recruit new people in. And they've continued to work and to deliver throughout that period, and they should be congratulated for that. And at the same time as that we were going through all that sort of logistical change, we've also changed our operating model to make our work much more seamless, to take layers out of the system so that we can provide a better service. And as Rob also described, took a decision to develop a very significant training programme for our staff. And that's not just about professional technical skills. That's also about training and development in emotional support. So issues such as mental health awareness and vicarious trauma and some of the things that, that Bernard was just talking about. And the key outcome for me and for Rob in all of that is about delivering the best possible service that we can deliver to all of you in the room, to everybody that we work with. So, before we close today, I want to say a few thanks to people. So, first of all, I'd like to thank our very inspirational speakers, but also the people that hosted and facilitated our workshops, who were really important in making sure we had a really stimulating and challenging day. I want to thank Bernard for coming up to spend the afternoon with us in his really busy schedule, and I hope that you'll take from that the same as us, the degree of importance that he places personally on wanting to improve public services. And then a thanks to the team at PHSO that organised this event, to Maria and the rest of the team, because to put on an event like this takes a lot of hard work, and they did very well in getting us all to the right place in the right time, and this event moving smoothly. And then finally, to all of you in the room for helping us with our intention to be a much more open and outward-facing and listening Parliamentary and Health Service Ombudsman. And everything that you've said to us over the course of this afternoon, we will take, we've listened, and we will think about and take into the development of our new strategy. But just finally, and I promise it is final before I close, we hear a lot of criticism about our service, a lot of very public criticism, and but what we don't hear very publicly are when people say very nice things about our staff. And increasingly now, day by day, I'm hearing those things as we start to change our service and to start to be different. And so only yesterday evening, when I was here at the hotel, I was reading a copy of a piece of feedback that was sent to us from a complainant to one of our investigators, Russ Griffin, and I'm going to name him because it's on our YouTube channel. I think it's really important. And I want to read it out to you because this doesn't happen very often, and I thought I'd get the opportunity to say that. And this was an email to Rob that I received, to Russ rather, that I received yesterday. And it said, "Despite the length of this reply and my disagreements on some of the points you have raised, I find myself in a position that is somewhat unusual for me. That of offering an apology to you for my previous correspondence. Although I have some outstanding issues, I cannot fault the process you have taken to come to your conclusions, and it is both refreshing and unusual to see someone place their logic in plain sight in such detail for it to be scrutinised by a hostile third party. This takes both courage and integrity, and I apologise for my previous correspondence." So thank you to Russ for what was clearly a very, very well-handled complaint. Thank you to my team in PHSO for working really hard day after day to address your complaints. And thank you very much to you for helping us on our journey. So have a safe journey home. Goodbye.